go. Perfect. Thanks, Monica. All right, so welcome everybody this morning. We're having one of our first healthcare IT community coffees. We actually have quite a few healthcare companies that have joined Palm Beach Tech, so I'm really happy to bring some of them together this morning. So I first wanted to just introduce myself and a little bit about Palm Beach Tech and what we do, and then we can go right into the speaker intros and right into our conversation. First, my name is Nikki Caboose. I'm the VP of Development for Palm Beach Tech. And I've actually got Ali and Monica on here as well this morning. They are our talent interns, Ali, and membership engagement specialist, Monica. She's the one that's been helping me with the technical side this morning, so thank you. And basically, we are a tech nonprofit. We started almost exactly 5 years ago. This month, we actually are celebrating our 5th year anniversary. And we started in downtown West Palm, built out into a Palm Beach County-wide organization, and actually just announced a little over a month ago that we are going to be becoming a regional organization for South Florida. And our whole goal and mission is to build South Florida out into a tech hub. So we work with a lot of the colleges, universities, the coding schools, the local headquartered companies here in South Florida. And as well as the talent. We have for instance, our virtual career expo coming up on July 15th. And for anybody that was wanting to join, actually, we have our anniversary happy hour on July 29th this month. So I will, as we go, actually, Ali or Monica, if one of you can help me as I'm talking this morning, just drop like our website and like virtual career expo links and all that in the chat, just so you guys have that information. And of course, anybody's welcome to reach out to us if you're interested in the organization, have any questions, or want to get involved. But I'd like to go right into this morning to introduce our speakers. And I am going to have some assistance from Aliya Aaron this morning. She's actually the founder of AMR Healthcare and the Nursing Innovation Hub. And she comes from both the clinical side and the technical side. So that's why I'm going to elicit her help this morning and just getting some of the questions kind of clarified from a clinical side as well. And then we also have Steve Seeley, the VP and COO at Jupiter Medical Center. Meggie Soliman, Director of Strategic Innovations at DSS, and Brennan Mason, the CMO at Bridge Connector, all of our current Palm Beach Tech members. So before we get into the actual discussion, I wanted to see if we can have each of you just briefly introduce yourselves, tell us a little bit about your role in your companies and what you do. I'm just going to go in order of my screen. Meggie, if you'd like to go first.
Sure. Good morning, everyone. So as the Director of Strategic Innovations for Applications at DSS, my role is to work at an organizational level and oversee our strategic roadmap and look at where can we innovate and make sure that we're ahead of the healthcare technology industry and looking 2 to 3 years ahead, right? And so as we know, technology is changing, and so our role is to really focus on where do we want to be and where is healthcare going from a technology aspect.
Perfect. And next on my screen, I've got Brennan.
Hello, good morning. This is Brennan Mason, Chief Marketing Officer at Bridge Connector. Bridge Connector, a technology company working to simplify healthcare integration, founded right down in Palm Beach Gardens, Florida. My role at Bridge Connector as Chief Marketing Officer is basically do anything and everything that revolves around growing and developing the business. And in the last few months, a big slice of that has been in crisis management and crisis communication, which has grown, particularly in the last few months, as a bigger piece of the pie there.
Perfect, thank you. I've got Steve next.
Good morning, everyone. I'm Steve Seeley, and I'm the Chief Operating Officer here at Jupiter Medical Center. Jupiter Medical Center is we're a regional medical center. We're more than just a hospital. We're about 250-bed hospital, but we also have a physician group. We have 5 urgent cares. We have several outpatient centers as well, really to meet all the healthcare needs of the community as well. My role really is, I'm a nurse by background, actually, but I really oversee most of the operations of the organization. We are, from a healthcare IT standpoint, I mean, there's hospitals and medical centers are very dependent on information technology nowadays, and we're getting more and more into that field and and we're very, very dependent on it. So, we are very always looking ahead as to where, how we're going to use IT to really provide better patient care and as well as better clinician ease of use and improving their efficiencies as well.
Thank you, Steve. And last but not least, Aliya. Oh, I think you're still on mute. Sorry. There you go.
Hi, I just said in my head, I won't be on mute when I start talking, and look at that. Good morning, everyone. My name is Aliya Aaron. I am a nurse and software developer and entrepreneur. I'm the founder and CEO of 2 health tech IT companies, AMR Healthcare Consulting, which is a software development and consulting firm for large enterprise organizations, as well as Nursing Innovation Hub, which is a innovation technology platform used to innovate, accelerate, and fund nurse-led startup and healthcare innovator software and medtech development.
Perfect. Thank you again, all of you. And I am going to go right into the discussion. For anybody that is listening through social or anybody here that's in Zoom, please feel free to drop any comments or questions in chat or in the comments on Facebook or LinkedIn. I'm going to go right into it. So I wanted to start off the conversation, but just kind of talking about the history over the last maybe decade or so. Can any of you comment on what have been some of the major changes that we've seen in healthcare IT? Because I think over the last decade, there's been a lot. Whoever would like to start.
So I'll start, Nikki. This is Aliya again, everyone. So, healthcare IT has definitely changed over the last decade. Initially, we were really focused on developing EHRs from the beginning, which we still are focused on, but we're more so looking at how to optimize and improve them for the workflows that we have now, because most organizations currently have an EHR. Is it being used properly? We don't know, right? But they do have them installed, and they're looking to either continue with the EHR that they have or look to purchase a new EHR because they're looking for an EHR, electronic health record, that can really speak to the clinician's workflow. We pivoted to telehealth as well because of the pandemic. Telehealth was already on the radar, but because of the pandemic, it's moved to the top now, being able to extend our reach into the communities and the underserved, and being able to work with our patients while we're, social distancing and so forth. So those are just 2 examples of how healthcare IT has changed over the last decade.
Yeah, this is Steve. I'll jump in on that. I agree. Over the last decade or so, EHRs, have been around a lot, but they've evolved tremendously from 10 years ago or so. The government mandated a lot of changes through meaningful use, legislation, which made us accelerate, I think, a lot of the ways we're using our EHRs and become more integrated and really more purposeful. And I think that I echo that. Are we using them to the fullest potential of them? No, we really need to look at optimization more. I think of the electronic records, but the other thing that's changed a lot is related to healthcare IT is device integration. So a lot of the equipment that we have, the monitoring equipment, the IV pumps, things like that now are becoming much more sophisticated from a technology standpoint, that now we can connect them to our EHRs. They have a lot more capabilities and information in there that really help provide the clinicians, I think, better ways to care for patients. Also improve safety. A lot of these things have really helped, I think, with safety features where to cross-check things so that you don't put the wrong doses in and things like that. So I think the technologies continue to evolve on that. Telehealth, I think, was a great example of that, where it really was not utilized really much before until the pandemic, primarily because you didn't get reimbursed for it. It was really a cash pay business. So people really weren't adopting that as well. And they like the face-to-face. I think that has flipped significantly now with that. And I think telehealth is something that's probably going to be here to stay. We'll have to see how the reimbursement ends up staying with it, because there's discussion, right now you're getting paid for it, but if you don't, we'll see. But I do think patients have gotten much more comfortable with it, as have clinicians. And I think it really has a value. I think you're going to see that probably grow over time.
Yeah, I totally agree with you, Steve. And speaking about devices, I think over the last 10 years, not just the things that are within the walls of the hospital or the facility, but think about all the different ways that patients themselves can track themselves outside the walls of the facility. And I think the last few years specifically, we've just really started figuring out, okay, how can we actually incorporate this patient source data that's not coming from our facility into our workflows or into our EHR. And we're seeing some really interesting use cases, like those blood pressure cuffs that you've seen in grocery stores and Publix for, decades. From now, there's a company that's sending that data for the high risk patients, people with, comorbidities, directly to, the EHR of a health system that's carrying risk for that patient. So some of the actual incentive behind doing that, I think, is driven by value-based care, because of course, in a fee-for-service world, there's not really a monetary incentive to necessarily do that, even though a lot of people would say that is an interesting thing to do. So I would say that over the next 10 years, that will be something that will really, really take off as well. Thinking about how we engage with patients outside of the walls of the facility with all these devices and tracking and things like that. I think patient compliance, though, is going to become like a looming kind of, I don't want to call it crisis, that's a little strong, but if we can't get, let's say, a clarification from the legislative side when it comes to just the clarification of how to use patient data and how patients can opt into having their data being used, it causes a lot of gray area. And in healthcare, because the fines can be so steep, you always have to be 100% sure that you're on the right side. It's not something that you can be 99% on. So I think if we can get a clarification on that, that will also accelerate the innovation there.
To add to that, patient care has changed from just being within the confines of a facility, hospital or your doctor's office, and now has become whole health and continuous patient monitoring. You have a lot of devices that are integrated within mobile apps, and your physicians are getting real-time patient updates, patient care information. So I believe now with this pandemic, we have moved more towards in that direction, and now that's a push for us to incorporate that telehealth much quicker.
Yeah, and not even, in addition to telehealth, we're talking remote patient monitoring when we look at how we can longitudinally track the patient from the time they, see the provider in the clinic to if they're admitted to inpatient, we discharge them, we follow them home. We look at remote patient monitoring and all the data that we can collect and analyze from there to look at trends in population health. So I think, we've come a long way, but we still have a long way to go, because as we incorporate these new and, again, innovative technologies to really help us understand the trends in healthcare and how we can better improve our patient outcomes and clinician satisfaction, because I'm a nurse. And so I'm always looking at how we can improve our clinician satisfaction, because it's very important.
I think one other thing related
oh, go ahead,
to that,
Steve, sorry.
Oh, I'm sorry. One other thing related to that would be really getting patient adoption of these type of things. We have a lot out there, but people just haven't got that comfort level yet. I think it's still relatively new to a lot of people. I think, there are the privacy concerns still, of course, that what are you going to do with this information? I think people always worry about that. I think the younger folks now, who are very tech savvy, I think are much more comfortable with that. So I think it's going to evolve over time, but we do have to really make people understand, what's the value to doing this to me as a patient? So if I want to do all this, what's in it for me? Whereas like insurance, if you get the monitoring and you're putting your data in, do I get insurance discounts? There's lots of, ways that people could be rewarded for those things and really improve health overall and probably drive down costs if people were more compliant.
Thank you all for those comments. We're actually going to talk quite a bit about some of those comments that you just made, so thank you. We actually have a comment in chat. I think this came from Social as well. Steve, it looks like you have a fan. They said, Steve, good points. I'd like to learn more post-show. And then somebody left their email address. If you see that in chat, they're writing, I guess, a piece, a blog for a podcast on HIPAA and telemedicine as well. But I can send you that if you don't have that. So one of the next questions I wanted to ask, this actually came from Meggie, so thank you, was just with continued innovation allowing us to, offer better patient care and outcomes. When we look at South Florida's demographics, what are some of the aging technologies that we need to address, the things that are kind of aging out or older?
I think I think there's, looking at aging technology, this that has been talked about for quite some time. And I think this pandemic is now forcing us to really evaluate, aging tech discussion. We've all heard about age, 2.0. And so looking at where we are today, the pandemic has forced all of the aging community above 65 and older to really try to stay home, quarantine, but have we provided them from a technology aspect the tools that they need to continue their care remotely? And so these are discussions we need to start having, as Palm Beach County, looking at our population. That is a huge part of the Palm Beach County population. And so in 2030, the statistics are forecasting that the majority of our population, for the first time ever in history, will be 65 and older. This is the first time that the aging population will outnumber the children. And so looking at that, we need to really collaborate and identify tools that we can give them, that they can continue the care. And so the pandemic has really forced that. And I think a lot of them are home and they're looking at, okay, what do I have? What can I use to continue my plan of care?
Perfect. So you were meaning more the actual demographics of the patients themselves, like the aging patients.
Yes, absolutely. Right. And so, we talk about their comfort level using technology. Mm-hmm. And so we have forced them to stay home. And so I think now they have become more comfortable. You see just with, groceries, a lot of them had to order their groceries online. Majority of them would have preferred to go into the grocery store. And so this really needs to become a shift and a priority from the healthcare technology organizations. And how can we really work together to give them the tools that they need to have that, plan of care and continuous care.
Right, because as we talk about acceptance and we talk about compliance, in order to be compliant, you have to have the right resources and tools to be able to be compliant. So we can't, continue to elevate our telehealth platform and continue to elevate, our extensions of care into the community without the community having the appropriate resources. So we would need funding and to provide those resources for the community, or else you will have non-compliant, but it won't be because, they don't want to, because I think a lot of people, particularly during the pandemic, they are scared to go out. And so they would rather be home and have someone have those resources at their fingertips. But as we see the numbers increase, particularly in our minority populations and underserved communities, do we ask the question of why, or do we assume that they aren't getting the care that they need? Or is it because the care that they need is not available readily in their community, or the resource is not available? So we have a lot to tackle.
Eva, Brennan, did you want to add anything there?
I agree with what Aliya says around accessibility to care. We've seen some perspective shifts where certain providers just believe that certain demographics wouldn't utilize technology. Again, let's go back to that blood pressure cuff example. But what we found out was, by kind of looking at the data, was this particular group was living in a food desert. There was no grocery store within miles of where they lived. So we had to think about how we could have made that technology actually accessible for everyone. It was easy to use, it just wasn't accessible for them. So I think accessibility, and if you were to start a new, say, ancillary care clinic or anything like that, you would look on a map and get some data about what the most profitable place to do that is. And that's fine, because that's a business decision, but that doesn't help the accessibility conversation, especially for someone who doesn't have transportation. They have to use public transportation. They depend on a ride. So you have to balance those business decisions with an effort to make care and technology accessible for everyone.
I think, all your points are actually very valid. The resource availability is a big issue. I think for people in some of the underserved communities, I think there is limited, government and county type resources and funding for some of these things. I think it needs to expand. We actually have a local partnership with Department of Health and the Healthcare District, really to help fund a free clinic up here in Jupiter with that. But even that has its limitations. And especially when you talk about getting into technology, because it is expensive and really trying to justify the return on that investment. Where am I seeing it? You know, you have choices to make. And so you have to prioritize what you can do. And I think technology innovation has probably not been that high on it right now just because of some of the expense. But I do think, you know, if that investment were probably made down the road, you would see that. You just don't see it right away.
Yeah, and something else to kind of put a name on this, you know, social determinants of health is something that has really emerged in the last few years as something to think about. These are traditionally things that providers maybe didn't think were things that would fall into their court, providing transportation, ensuring proper access to food. But, you know, when you boil it down, you can't manage your diabetes if you don't have access to nutritious food and you can't make it to your appointment. It's pretty basic. So when we actually incentivize outcomes, you know, with value-based reimbursement, there's incentive to focus on these social determinants of health as well.
Yeah, and there's a question in the group chat from Allison Cassell, and she asked, are social determinants of health embedded within the EHRs? And the answer is yes. Most of the EHRs have embedded social determinants of health as criteria to be admitted upon. The nurses typically ask those questions of those patients, you know, and on discharge too, because before we discharge patients from the hospital, along with the case managers and those on the interdisciplinary team, we'd like to know, do you have, you know, stairs in your home? Do you live alone? You know, is there a grocery store near your house and so forth? So they've tried to include those into the EHR so that we can better get a sense of how to follow up with these patients, because we want to utilize our healthcare IT, particularly our EHRs, to help us decrease our readmission rates. So if we send these patients home and, you know, say a little old lady, she fell at home, her hip was fractured, she had surgery, we discharge her back to her home, but she has no one there to help her. She lives with stairs. You know, she might have a whole bunch of cats there that she trips over, who knows, right? And so, you know, we want to be able to understand her living arrangement, so that, because we want to look at our population holistically, not just inpatient acutely. We need to look holistically at our patient population to see how can we help them as they move through our healthcare system. And I think healthcare IT, well, I know healthcare IT is an enabler for us to do that by, you know, having our remote patient monitoring, having our telehealth, utilizing our EHR on in and out of the hospital, and other ways that we can improve our outcomes with these patients.
Yeah, and to add to that, Aliya, I think that goes back to the whole health, you know, aspect of patient care. It's no longer about a specific diagnosis. It's about looking at their entire lifestyle, their diagnosis, their exposure, things like that. And so in order to really have some, you know, artificial intelligence and look at forecasting, patient monitoring, real-time localization services, these are things that need to be now incorporated within their health record.
Absolutely, especially as we look at data and looking at machine learning, how we can utilize the machine learning to really help us be more intelligent and strategize.
And I'd like to actually kind of ask a part two to that question, because you guys actually answered my next question, was just about the underserved communities. But I'd also like to ask, as we're trying to do better with the technology and keeping more data and learning more about our patients and how we can better, you know, care for them, how are we getting the message out to them or educating the patients on what's being, I guess, put together or offered now? Like, how are they actually getting that messaging?
Through a lot of them get all their information through Google, but you know, I mean, that's just where we are now. But you know, we have to be better at that. The messaging is there. A lot of the hospitals have their communication boards, the physician practices. We have a lot of organizations that are now spreading the news. There are many different ways that the community gets educated on what's going on. Some ways are better than others. So it would be nice if we could really put it under one umbrella and make it make sense, so that they're not having to use Google Doctor.
I like that, Google Doctor, yes, because that's often what happens.
Yeah, there's not one solution for it, because I think there's definitely, you know, everyone learns and gets their information in a different way. As a hospital, you know, we do that same thing. You know, we do things through our website, we do email pushes of information, we do things on social media. You know, there's a variety of different ways that we really try and get information out and push information out to patients as well, and then really try and link them back to the system. so that they seek us as resources and they look at us for different types of things, for information. And then as we're evolving as well in this. So the more we see interest, that just helps us develop information and get that out in different ways to meet the needs of the community and what people are looking for. And you're right. I mean, everybody comes in armed with their Google information when they come to the ER. They've already diagnosed themselves. But and that's just the world we live in now. And so you just have to. Everybody had to get comfortable with that. That we have a much more educated consumer than we used to have.
Yeah.
Very true. And we actually had a comment here. I think it was to your comment, Aliya, has anyone considered applying for grants through the CARES Act? If you guys could talk a little bit about where funding comes from and what efforts maybe have been made in the healthcare community.
Well, my companies have certainly taken advantage of all the different opportunities that are readily available. And so we seek funding and opportunities from there. But there are many different avenues which organizations can reach out for help. And I think over time, more will come on board as well.
We've been exploring, sifting through the myriad of information in the CARES Act to really try and understand what's available. Most of it really has been related to disaster recovery type of funding and those type of things. The grants itself for other things has not really been, I would say, embedded that greatly in the CARES Act. But we're still weaving through it because there's a lot of little line items that you don't really know if you qualify or not. So we're looking for any funding opportunity we can get, though.
Yeah.
Yeah, and for us, we're kind of purely on the vendor side, so there's really not much there for us. However, we have been working with our provider customers because we have a kind of a quasi policy arm here to help understand the landscape that's been helping some of them navigate, and particularly some of these small, home health agencies, skilled nursing facilities are really struggling to help see if there is something for them. And a few of them have gotten some help, but like Steve was saying, there's so many. Sometimes you just don't know. I mean, you can read the whole thing and still not know if you actually qualify for something, and that's just. And in that case, we just say, well, just go for it and see what happens.
And outside of, the government funding, we take advantage, particularly through Nurse Innovation Hub, we're looking to take advantage of a lot of the funding options that are available for startups that are really looking to develop new technologies that can help during the pandemic and beyond. And so out of COVID and the pandemic, a lot of companies have come on board and realized that now is the time to really get innovative and come up with new ways outside of what we're currently doing to say, how can we best, treat these patients given what we have, given what we know. There's been a lot of hackathons involved where we have our clinicians involved to talk about, particularly like from the bedside, what have they seen and what do they think could potentially work. So we are involved in a lot of that type of funding information to see where we could potentially get funds from to really help some of these startups that could potentially be profitable in the healthcare space and commercialize some of those solutions.
Now we have actually gotten some grant money from the government, that they pushed out to hospitals, in the initial stages, because this has changed our world dramatically. I mean, it's just turned our world upside down. And we've had to institute new technology actually to help us navigate through this because we're just doing business in a completely different way. We now, have to screen everybody coming into the hospital. So we implemented these facial recognition thermometers called Care AI thermometers, which are really cool actually, and takes your temperature like that and recognizes your face. So it goes faster each time. And then and we're learning all the different things that can do beyond just temperature screening. It also can integrate into our timekeeping system. It can send alerts. It can do all different type of things. We've developed a patient tracking system, which really is almost like a social distancing system, so that we can talk to patients, through secure texting, so that they can stay in their cars or wait till their appointments and things like that. So we've used some of the funding and really to help fund some of this new technology that we've gotten as well.
Mm-hmm. And really from the vendor side, from a technology aspect, you really have to, although you're not directly impacted by the funding, you are in the sense of That's where you need to be innovative and really provide the tools where they are getting that support, where they are getting that funding, right? So telehealth, that's where you need to pivot and reprioritize and make sure that you are providing your customers with the tools that they need so that they can take advantage of this funding.
Thank you. And yeah, actually, Steve, I did get a chance to use, what was it called again? Care.io, is that what it was, the machine?
Care AI.
Care AI, yeah, I did use that when I was there. I went to go visit the new cancer center recently. So it is actually pretty cool. It's a lot better than having those little plastic guns they stick to your head, and it's a little awkward. So yeah, it's nice.
Yeah, no one
I
wants
hate
to
those
touch
temperature
by
guns,
anything
but
right now, right.
yeah, no, it was actually very, very cool. It was an easy experience. It was quick. It was much faster than those little gun things too. Like it was nice. I liked it.
Yeah, we're
But
one
I
of the only
did
two
want
hospitals in
to.
the state that have it, actually.
Oh, really? Okay, I did not know that.
Yeah.
Thank you. That's very cool. I did want to talk about, which I know for the people that are in healthcare IT, sometimes this is a touchy subject because I know you guys are working on new technology and innovation every day, but there is that age-old argument of some saying that the healthcare industry is behind when it comes to like leading a path for new innovation in tech, especially on the IT side, because it's such a highly regulated space. And I've heard the argument multiple times where, oh, they can't be a leader in that space because they're scared to implement things and kind of be the first on them because they need to see how it works in other industries first and so on. Where do you believe that the industry as a whole may be lacking, and where we can better prepare our hospitals and healthcare providers in the future? Like, what are some of the things that we are working on?
Well, I think it's three parts to that, right? So you have the process aspect of from the development side, right? And I think something like this really challenges how agile are you, right? So your mission's the same. You want to improve patient care. You want to lower risk. You want transparency, all of that. But are you able to pivot and how change, right? And then you have the second aspect regarding the software. And so you have telehealth, patient monitoring, AI, contact tracing. These are things that are being discussed now. And so that's where you need to be innovative and ensure that you are implementing these types of tools from the software. But thirdly, I think an area where we really need to be talking more about is interoperability across different healthcare systems, right? And the legislative aspects around that, and the patient really owning their patient record, right? So we're in a pandemic where if you were to contract COVID, which I hope, I don't wish that upon anyone, and you have to be checked into a hospital, you are your own advocate, right? You are not allowed to bring someone to come and speak on your behalf. And so are we looking at the interoperability of our patient care, that you can now bring your record with you without trying to have to, disclose this to the primary care provider that's giving you this care under a crisis, right? And so these are discussions I think we need to have more of, is working together, and how can we better collaborate as health IT organizations to really give our physicians and clinicians that ease of access of patient data, and also giving that patient the empowerment to own their patient record.
Yeah, I think, obviously as an interoperability vendor, I would co-sign that argument for sure. I think Nikki, to your point, it's hard to argue that there are not areas of healthcare that are very far behind. And to empathize though a little bit, the stakes are very high. If you make a big bet on something in healthcare, and it doesn't work out, people could die. I mean, in the worst case scenario, you make a big bet in manufacturing, you lose a little bit of money. Now, I think that that's been used as kind of a safety net to block change though, because the stakes are high. I think, the industry goes a little bit too far to the extreme. And not just, when it comes to patient care, but just from regulatory, penalties that you can suffer if you, have a data breach or share a patient's data with a vendor you weren't supposed to. There's a lot of very bad things that can happen if you do the wrong thing. And these bad things scare a lot of, CIOs, et cetera, in healthcare to just do the safe thing. And I empathize a lot with that, because doing the not safe thing carries an extreme amount of risk. So I think there are some things that can be that can be done to clarify, the regulatory environment for, a world of 2020 and not, the world of the 90s, and which is, what some of the regulatory environment is written off of. And when it comes to interoperability, there's, the ONC just, before kind of COVID dominated the headlines, the ONC had wrote a final rule for interoperability to finally push some, there's a lot of things it did, but it particularly focused on pushing some vendors to be forced into interoperability. So if you're an EHR vendor, you can't data block anymore. However, there's a lot of, well, if this and if that in there. And there are still a lot of EHR vendors that monetize patient data. And I think there has to be a conversation about whether or not an EHR vendor can make money off of your healthcare data. It's not just whether or not they have the right to do that. The cost that they put on that just blocks a lot of organizations from being able to do that. You're talking about sometimes, 75 cents a patient record, which might not sound like a lot, but when you start dealing with, thousands and tens of thousands of patient records, it gets very expensive, so expensive that it becomes not a very good business proposition to actually do. And you default to the old safe ways of doing things. So I was really excited. And I think the timeline will almost certainly have to be pushed back for, what the ONC originally put out, because there's just no way that any organization has had the time to focus on, moving the needle if they had to. But I am cautiously optimistic that will kind of be the first step towards some, government intervention, which is always a very scary word. But in this case, I think a little bit okay, in the world of interoperability.
I think from the hospital perspective, I would agree with you, Nikki, that, we are behind the times in a lot of things. I think healthcare has done a great job with technology to take care of patients. But when it comes to the EHR side of it and all that, it's a challenge. Because, you just look at Palm Beach County, there's several different, healthcare systems in the county. We don't talk to each other from an EHR perspective. So patients can be in our hospital and they go down the street to another hospital. It's a completely different EMR. We can't connect together, even though the HIEs, were supposed to solve that. They haven't really gotten very far with those type of things. So the data just doesn't go anywhere. And I think that, I do think there's issues, of concerns from proprietary standpoint from the vendors, that they don't want to let their information out. They don't want people to know how it works. So, it just kind of stagnates. And I don't think the intent was to get to that point so that the record followed the patient more around the systems, and the areas or wherever they are in the country. It just hasn't gotten there. And I think that's, and I think, with the regulations between HIPAA issues and all that, I think it just has everyone's just stepping back because no one wants to have a breach and pay the huge fines and the bad reputation that your records got out and this, and no one wants to get hacked now because you have to worry about, if you open up to exchanges, are you more vulnerable to getting hacked, and those type of things. So there's a lot of work to do. I don't think it's going to be solved in the immediate future.
Yeah, and I did want to make a comment there, Steve, because I think Aliya and I may have had this conversation last time we had coffee, but I actually came from the healthcare industry. I've only been in tech for a few years, and I actually started in healthcare, placing physicians right when I think EMR, EHR was implemented in the hospitals and was made mandatory. And this actually, what reminded me is there was actually a comment in chat about the shortage of professional talent to implement some of the changes. And I know that for me, that's what we were dealing with a lot of the company that I worked with, is that when EMR and EHR became mandatory, that there was already such a lack of, there was already such a physician shortage that when it became mandatory, a lot of people don't realize a lot of the physicians were between 55 and 65. And that older generation was like, look, they were retiring early, they weren't getting the technology as quickly, so they were not able to see as many patients as normal, and that slowed. And then, of course, like you were mentioning, just the ability to talk to the different hospitals. I know one frustration that I always had was even just credentialing. Credentialing departments still are using faxes. And I feel like in so many other industries, fax is like, what? You have a fax machine still? But in the hospital, it's a very needed technology. And so it's a little crazy to see how such an older technology like a fax machine is one of the main forms of communication and getting these doctors and nurses, credentialed in the hospitals. And I just wanted to see, what was your, I guess, point of view on that, especially from the people that, like Aliya, that are on the clinical side. Just kind of, we think that's an issue that's going to go away, is that getting better? I know that was definitely a point of frustration for me.
Well, I mean, healthcare in general moves slow. Like, we are snails. We move slow. We are last to implement. I mean, the commercial banking industry has implemented new technologies faster than healthcare, but it's also, we are highly regulated too. Their regulations don't even touch where we are. So we have to, we move slow, but we implement smart. And, a lot of facilities are still using fax machines. And so we look at how can we improve these workflows to reduce redundancy and tasks. And it's still going to be, an issue, because we have to move slow in order to correct a lot of what's been going on. And it's been going on for a long time. So, we just take it day by day and inch by inch as we, look to really bring on these new ways of processes of doing things in healthcare. Because we have to be really particular. It's not like in technology how we move fast, we break it quick, but we can't really break things in healthcare. It won't be good.
Yeah, I remember it was about 10 years ago, hearing a lot of people saying that the fax machine would be dead in healthcare in 10 years. And here we are, and it is still almost just as alive as ever. And again, this is, we're working in a world where a lot of these regulations were written in the 90s and just not for the world that we work in today. And there's a lot of risk involved with doing any type of experimentation there. And, if you actually break it down and think about how secure a fax machine is, I know we've gotten, especially in healthcare, we've gotten some really snazzy fax machines, but, you're sending at the end of the day, a mysterious piece of paper with all kinds of information on it, some unknown place, and you don't know who's standing on the other end of that machine. It's really not that secure, fax machine, but the way it is today, that is like the secure method of communication. So, we really have to we almost just need a total revamp. I'm a really big advocate for this, a total revamp in, the way we think about HIPAA in particular, and how we can share information in a secure way that makes sense for a 2020 world and not, a 1994 world.
Yeah, I mean, particularly in this pandemic time, think about, we live here in Florida and the cases are rising in COVID, but you have people that are traveling in and out. People are still wanting vacation. So they come down here to Florida, they may get sick, they travel back home to New York, and they may visit one of our hospitals here in Florida. How do we communicate this to the practitioners, the doctors, and so forth out of town when they go back? Now they have to tell their story all over again. They can't have somebody in the hospital with them. So it just gets really muddy. And how does this help us as we try to navigate this pandemic water?
I would love to say we never used faxes here in the hospital, but I'd be lying. I do think it's less than it used to be, because we do have those concerns about, that's the wrong. So we're very careful, I say, what we fax these days. Physician offices, though, Nikki, you're absolutely right. They just are in the dark ages, many of them, and they can't live without their faxes still. So we are more dependent. Even though we've moved to an electronic credentialing system, we still get faxes from them as well. But I would say patient information, that kind of stuff. We do very little of that nowadays, just because of the risk of, you don't know who's really getting that fax anymore. So it's a little too risky now.
And we've even taken on projects. Steve, we'll be kind of in the middle of that, where we have a health system that doesn't want to accept a fax, and a provider site, a small provider site that has to send a fax. And so we'll do an e-fax integration. So we're just kind of dragging people along, as we just barely make progress on the fax machine side of things.
Well, I mean, people are still getting discharged from the hospitals. And the last time I remember, we were discharging people left and right out of the hospital, going to SNFs and LTACs, and we were sending over all their documents on fax.
Mm-hmm.
Yeah, and back to your question, Nikki, I don't think it's really around the talent, but it's more so around, like Brennan was saying earlier, the users then are taking that risk, and no one wants to be the first to have a an adverse event while using a new technology. And so we're going to be at a point where majority of our healthcare providers are going to be millennials, right? And so I think that they are open. I just think it's that risk that they are hesitant to take. And so it may take legislative action for new technologies to be implemented.
Yes, thank you. And I see a couple of comments here. One says a fax machine is only secure if the recipient is standing on the destination. Fax security when outstanding claim billing. Okay, so yeah, I can somewhat agree with that. I think also the part two of that, and always my concern was even just timing. I know that I had physicians that I was working with that literally had patients die because they couldn't get credentialed in the hospital, couldn't get, if they were like, say, a specialty physician, where it wasn't necessarily the information not getting to the hospital, it was the timing. We had to send things over and over and over to make sure that it went through or that type of thing. So I think there's definitely two parts of that as well. There was a
question around telehealth technology, and if telehealth is being utilized not just outside of the hospital, but particularly like in acute care settings. Let's say patients in the hospital, but they have a power of attorney that can't be available at their bedside. Are we leveraging technology to be able to have them at the bedside via monitor and so forth? And I would venture to say that this is happening, not probably as adopted, nationwide, but I know some hospitals have started to adopt rolling in the carts. They've been very creative in putting using the wows, if we call it, or whatnot, and being able to have the patient's families see them, even just using regular iPads. Some of the regulations have been laxed to be able to allow this to happen during the pandemic.
Yeah, we have done that as well. We have utilized, because visitors, we really had to restrict who can come in and out of the facility now. We've been doing a lot of FaceTime with our patients with iPads and and giving that as well. It's worked actually very well. I think everyone's gotten comfortable, and has been some rule relaxations for that. We also have some telemedicine carts that are a little more sophisticated that actually have technology attached to them so that physicians can see remotely, especially we've used them in COVID rooms. So like a physician can view the patient, we can hook them up to different things, and they can see that to reduce exposure to patients. So we've actually adopted that as well.
Right. And, healthcare IT extends beyond EHRs, extends beyond just the software itself. We've done work with robotics companies as well, where we utilize our nurse system robots to be able to lure them into the rooms and task them with things that need to be done inside of patient rooms. So there are a lot of developments around utilizing technology itself beyond just our typical, which we've been working with over the last couple of years.
And I think it can't just be, technology that's replacing, their paper or fax machine in this case, but it has to be a value add, right? So you have to be giving them something that they currently don't have, whether it be new data, different types of reporting, something different for them to be able to make that transition.
Yeah, and Aliya, there's a lot of EHRs that are really well put together. I know there's one particularly in South Florida, ModMed, really fantastic. But a lot of the EHRs they weren't built as platforms of innovation. They were built to build codes. And so if you're trying to innovate out of an EHR that was built to build codes, you're really kind of working from behind to begin with.
Right. Yeah. I tell, we work with clients, enterprise EHR clients, as well as build custom. And so, from a clinician standpoint, we build for workflow. We build because if you build an EHR to fit into the provider and the nurse workflow, everything else will align itself. Because if you build for the workflow, the processes that fall within those workflows will align with the financial side, which can then be coded and billed correctly. It's kind of backwards to bill for the financial side without knowing what the codes, codes match you on the clinical side.
I totally agree with you. I think, a lot of these are just built in a world of meaningful use where it's we just have to build something that meets the standard so that they can build these codes and we can get this grant money. And meaningful use, I think at the time, and this maybe not the most popular opinion, it was a good idea at the time, but it really it put us in a little bit of a hole, because I think that's where a lot of these bad tech EHRs were born out of, because there was really not a lot of concern out of, okay, what's the actual provider workflow? Like, how are we actually going to engage with the patients? It was just, no, we need something that meets these specs and we'll build these codes and get this software out the door.
And I think that's something that, DSS has actually done really well. We are engaging clinicians as we're developing, right? They are part of that development process. And so it's not just about having this great technology, it's about ensuring that you understand that workflow and you have those subject matter experts involved at the forefront of that development.
Right. And so the question about, are we lacking professionals? We aren't lacking professionals. I mean, there's always a shortage of nurses. We have, I remember working on the floor, there's always a shortage of nurses. There will never catch up, right? But we have knowledgeable expert professionals that are willing to share their knowledge. And I can appreciate DSS because I participated in some of that clinical knowledge sharing. But we have these professionals, but are they being asked to participate? That is a question. Are they being pulled into the room? Are they at the table having these discussions about what technology looks like and how it can help us? Because I've worked in this space for a long time, and being one of the minority, the woman, the nurse, and everything at the table. And I look around, I'm like, where's everybody else, right? So it's like, when do we bring the clinicians to the table and start asking questions and having them co-develop with us? That is what we really want to get to.
Well, we're dependent on like the major, EHR type of companies that are very clunky. And I think, Aliya, you're absolutely right. I think that they had input from some end users, but not enough, and not that they had sort of final say. I think with the push for the EHR, the meaningful use stuff, it became a check the box type of thing. Well, okay, we got this one done, we got this one done, not got this one done, not realizing, but it makes our workflow worse, not better sometimes. Because I do think that you need to have the people who are actually doing the work have a lot more say in how these are developed. And change in these systems is slow, very, very, very slow, because they have to change it for the masses, and it has to go through 300 approvals. So it's not really where it needs to be.
Right. And it's very costly too. It is very costly to implement an EHR, and to, once you have it implemented, to continuously improve the EHR to satisfy the quality and the outcomes and the data that we're looking for. So.
Perfect. We actually are almost at time. I did want to just wrap everything up with one final question. Obviously, the pandemic, is a negative situation overall. But how do you think that healthcare was like forcibly changed for the better? And are there things that can almost be a silver lining that we've learned out of this experience that we can take, forward and move towards the future? And I forget who made the comment about even some of the regulations kind of being a little lax during this time. Are some of those areas that you'd like to see continue going forward?
Yeah, I think it's a wake-up call. I mean, there are a lot of changes that need to happen in healthcare. And oftentimes we work on a project timeline. Our milestones are out, 18, 24, 36 months. We work very slowly to implement and change. But because of the pandemic, we've had to pivot quickly. You see a lot of new innovative approaches being done now that would typically go through 3-6 months just to idealize. And they've been, put to use in 2 weeks. So what's fascinating is that they were able to really implement these new changes so quickly. So why were we not doing this before? Why are we taking so long to get these new changes to the bedside and to the patients that can really benefit from them? Why do we have such a long turnaround time? I mean, even in clinical research that, the IRB process is long. The healthcare IT development and implementation is long, but then when a pandemic hits and you're forced to move quickly and implement fast, you all of a sudden can get things at the bedside in 2 weeks that took you 2 years to do. So the learning curve here is, let's not do that again.
I think from the hospital perspective, I think while this is very difficult for us all to go through, I do think there are some good changes that have come out of that. I think you're right. The speed to change has totally accelerated. I mean, you're not ruling by committee anymore. You're just doing it and seeing how it works. I hope some of the regulations stay relaxed, like for telemedicine, for example, and reimbursement, things like that. FDA approval process, I think, would be something that would be great if that stays a little more accelerated and not taking 5-6 years to get things approved. With that, I think some of the technology that has been instituted will stay. It's not just going to be, we're doing this because of the pandemic. I think a lot of these things actually are making care safer. And I think so a lot of these things actually will stick, which change a lot of our workflow, which I don't think is ever going to change, and not necessarily in a bad way. Most of all, I think it's made us much, much more cautious about infection prevention. So I'll tell you, I've never seen so many people wash their hands in my life. So that's a good thing, because that not only because of this, but for other infections, I think it's going to keep all that down as well. So I do think there is some good that will come out of this.
Yeah, I think reprioritize too technologies that were, thought of as just innovative maybe 6 months ago, and now they're innovative but a necessity. And so this has shown us that we can accelerate change, and I think that moving forward, we're all going to reevaluate, not just from the tech company, because we could push out software fairly quickly being agile, but are they able to receive it? And I think on the receiving end, they have seen the possibilities. They have seen that they can intake, applications, new software, new technologies that help them improve patient care fairly quickly.
Yeah, Stephen, you mentioned something, doing telehealth via FaceTime. If you'd said that a year ago that we'd be doing telehealth on FaceTime, people would have said you were completely crazy. Telehealth was crawling along so slowly, where first, a patient had to go to a telehealth site, which is just bonkers to even think about to begin with. And then it's like, well, okay, if the patient is 50 miles away and they own 3 chickens and they live on a farm, then okay, you can use telehealth. And we saw, not literally, but almost overnight, just an absolute deregulation of telehealth that I think has been almost all net positive. And I am very optimistic that we will not snap back, and that this deregulation of telehealth will stay, because I think it's been really fantastic.
Thank you for that last comment, Brennan, because I agree with you. I'm hoping that this experience really was a huge wake-up call, and that we will not move backwards learning from this experience. So thank you so much for that. And that was a great final comment to wrap that up. But we're right over time. So just to be cognizant of everybody else's time and schedule, I want to thank everybody for joining. And I still have a million questions. So hopefully we will be able to continue this conversation again and have a part 2. I'm sure we'll hear more from our healthcare IT companies. But thank you again, everybody, for joining. And thank you to all the speakers this morning as well.
Thank you all. Great discussion. Thanks for organizing.
Thank you.
Thank you.
Thank you. Enjoyed it. Take care.
Day.
Thank you.
You too.
Take care.